Hi everybody, Rich Savell here from the Surgical ICU. I'm here with my friend and colleague Dina Borgia. She's the nurse practitioner from the Surgical ICU, and today we're going to present to you a video on the ABCDEF bundle of care for the critically ill patient. We're going to be using as our slides, some slides that we borrowed from the American Association of Critical Care Nursing to help us provide you a structured approach. So let's get right to it. So Dina, do you want to take a few minutes here and go over the different components of the ABCDE bundle?
Sounds great, Rich. So basically, there's the awakening and breathing trial, and then coordination, which it will be coordination amongst the collaborative teams. And then you have the delirium assessment and management, which is another very important part of this bundle, as well as early exercise and progressive mobility, which is really, really exciting for the staff and the patients.
Well, let's get into some details here. So on this slide, the focus is on the multidisciplinary team, appropriately with the patient and family in the center. And you can see, without us going over this in too much detail, all of the various members of the multidisciplinary team working together and having a common understanding and a common focus. So let's begin by sharing with you some details of A, the awakening and breathing trial coordination. So Dina and I want to go over this slide with you in a little bit of detail because there's a lot here. At first, we're going to go over the entire overview with you, and then Dina's going to go over some more of the details. The idea is the first step is to do a spontaneous awakening trial safety screen, and Dina, you're going to go over that in a little bit. If you pass that safety screen, then you start by performing the spontaneous awakening trial. And from a clinician perspective, the idea is, although it's written down or used to be written down that you stopped all sedation, more and more data shows that it is just as effective to start to lower the sedation according to protocol to make sure that the patient doesn't immediately start becoming severely agitated if they fail their trial. It's important to note here that if you pass your spontaneous awakening trial, you go on to your spontaneous breathing trial safety screen. And if you fail your trial, Dina, it says here that, so what are we supposed to do with the sedatives at that point?
So you're going to restart them, but you're going to restart them at half the dose that the patient was taking to try and decrease the amount that the patient will require. Of course, as long as it's safe for the patient to be at that dose.
And so this is a major theme that you and I were talking about a lot that goes throughout this entire ABCDEF bundle of assessing the patient, assessing their need for sedatives and narcotics, but using the minimal amount of sedation.
Yes, that's pretty much what it's all about.
So the next step is once the patient has had their spontaneous breathing trial safety screen, if they pass it, you perform the spontaneous breathing trial, and again, the details of that will be coordinated with the nurse, the clinician, and the respiratory therapist, but the focus is if they do well during their spontaneous breathing trial, we're supposed to consider extubation. So Dina, I wanted to have you go over for us both the spontaneous awakening trial safety screen and what a patient might look like if they're having their spontaneous awakening trial failure.
Sure thing. So in order to screen the patient, you want to make sure that they're not having any active seizures, that they're not actively withdrawing from alcohol or exhibiting any signs of agitation. And it's really important that they're not on paralytics either. Also that there's no signs of myocardial ischemia and that they have normal intracranial pressures. So if a patient is failing their spontaneous awakening trial, they're going to look like they're not going to be comfortable. They're going to exhibit signs of anxiety, agitation, or pain. They'll be tachypnic, hypoxic. They may look like they're in respiratory distress, and you may see some arrhythmias on the cardiac monitor as well.
And this would be before we've even made any changes to the ventilator settings. This is just decreasing their level of sedation.
That's right. That's just taking off their sedation or lowering it and seeing how they do.
So the next step is to assess their spontaneous breathing trial. Although it's beyond the scope of this particular video, but as most people know, a spontaneous breathing trial can either be a formal CPAP trial, a low-level pressure support trial, or actually a formal T-tube trial. And again, that's going to be a consensus discussion amongst the members of the team. So if you start performing your spontaneous breathing trial screen, what are some of the criteria that goes into that?
So again, the patient shouldn't be exhibiting any signs of agitation. They should be oxygenating well with an O2 saturation greater than or equal to 88%. Their FiO2 should also be less than 50%, and they should be on low levels of PEEP, less than 7.5. Again, they shouldn't be showing any signs of myocardial ischemia, and no vasopressor use or inspiratory efforts. Although I just want to point out that even though this says that the patient shouldn't be on any vasopressors, there are some instances where a patient may be on vasopressors and the team will go ahead with assessing the patient for extubation.
So there could be exceptions?
Yes.
And then, yeah, so this is the pretty classic definitions of failing your spontaneous breathing trial.
Yeah, so the patient will be either tachypnic or bradypnic. They'll be hypoxic and in respiratory distress, and they may show signs of mental status changes. And again, you may see some arrhythmias on the EKG monitor.
So on this slide, it's just presenting in a colorful, circular fashion this collaborative approach. Again, starting out by everybody, the respiratory therapist, the nurse, the clinician, communicating and coordinating about the patient's status, making an assessment about a spontaneous awakening trial, looking at their safety screen, making sure if they meet criteria, beginning the spontaneous awakening trial, if they continue to improve, working and integrating the respiratory therapist into it, and seeing if they meet criteria for the spontaneous breathing trial screen, and if they do, starting the spontaneous breathing trial, and if they do well, extubating the patient.
So this basically looks like, it's a real team effort here.
That's what it is. It's all about everybody being on the same page and focusing in on what's best for the patient. So in this next section, we want to focus in on delirium. We want to focus in on some definitions of delirium. We want to focus in on how you, as the bedside practicing critical care clinician, can determine in a really reproducible way whether or not your patient has delirium, and if you do so, what you can do about it. So let's go for it.
Let's go. So delirium can be defined as an acute change in consciousness accompanied by inattention and either a change in cognition or perceptual disturbance. There can be three subtypes: hyperactive, hypoactive, and mixed. And hyperactive is the one that we tend to see more and is the one that is more identifiable because the patient will be agitated and restless and ripping out their IVs and trying to pull out their AT tubes.
So that's the obvious.
That's delirium. The obvious one. And the one that's less obvious is hypoactive because the patient can be more withdrawn and flat and have a decreased responsiveness.
And so it, from my understanding of the literature, is that with a focus on delirium, we're discovering many of these hypoactive patients that we might not necessarily have picked up on before. And that's one of the advantages of taking this kind of structured approach.
That's correct.
So one of the other issues that comes up is there are certain patients where you should have your antennae up that they may have delirium without you knowing much more about it than some of these key important points, and I'd like to share them with you. So the first is any patient that comes in and has a pre-existing diagnosis of dementia, they're at very high risk. Even something as simple as hypertension, because long-standing hypertension can make a patient more likely to develop delirium. Something that may be a little bit more evident is something like alcoholism. These patients may undergo surgery and have a pre-existing undiagnosed history of alcoholism and then may have delirium out of the blue. And then there's severity of illness. Somebody who's coming in and developing signs and symptoms of multiple organ dysfunction syndrome can manifest as delirium, perhaps as their first sign of multi-organ failure. So you have to keep that in mind.
So is there a tool or what do we use here at the medical center to assess these patients?
Great question. So there are a couple different validated tools to help determine if your patient has delirium, and ours here at Maimonides and at many, many hospitals across the world is the CAM-ICU, Confusion Assessment Method for the ICU. And Dina, why don't we show everybody how to do that?
Sounds great.
So this is the paradigm that I like when I'm sharing with trainees how to even think about the CAM-ICU. And the idea is that you need feature 1 and feature 2 and either feature 3 or feature 4. And I'd like to spend some time and go over that just a little bit. And then in the next couple of slides, we'll go into more detail. So feature 1 is acute onset of mental status changes or a fluctuating course in mental status and inattention. And Dina's going to go over more detail later about exactly how to make an assessment of inattention in your critically ill patient. And then you need to have either evidence of disorganized thinking or that your current level of consciousness is abnormal. So again, one more time for repetition, you need to have an acute onset of mental status changes or fluctuating course in your mental status and inattention and either disorganized thinking or an altered level of consciousness.
So Rich, is there one that we would see more in the ICU patient?
There is, Dina. In general, when this has been looked at, this approach, features 1, 2, and 4, appears to be the most common, that a patient comes in, has an abnormal level of consciousness now, that they've had an acute change in their level of consciousness, and they have inattention. This comes up when, as we're sharing with them how to do the CAM-ICU. So let's do that.
Let's go.
So step 1 is to determine the level of consciousness with a sedation scale, and the one that's recommended is the one that's on the screen here, the Richmond Agitation Sedation Scale. And there's a lot to this, but Dina and I only want to make a few important points here. I think the first one I'd like to make is, what would you say is a reasonable target that the nurses and clinicians should be focused in on for an intubated patient that requires sedation?
So a reasonable target would be a RASS score of 0 to -2, so basically an alert and calm patient to a patient who's mildly sedated.
Some of the other important points about the Richmond Agitation Sedation Scale is, as you can see, it goes from +4, which is combative,
We don't want that.
suboptimal, all the way down to -5, unarousable.
Sounds suboptimal too.
We don't want that either. So the important point here is that if you make an assessment of your patient using the RASS scale, and their RASS score is greater than or equal to -3, then you can assess the patient to see if they have delirium using the CAM-ICU. If they're -4 or -5, they are considered unevaluatable, and as you and I have talked about previously, your target should be, you should be aiming for your target. You should do what you can to try and get them to be not -4 or -5. So let me show you this, Dina. This is the real meat and potatoes of trying to figure out the CAM-ICU, and I thought we'd go over this in a little bit of detail because it's kind of important. So just in terms of helping the viewer map this to the previous slide, you need to have, this is the circle showing that you have evidence of delirium, and you need to have the blue box, acute mental status changes, and inattention. And then at that point, if your RASS score is abnormal, you have delirium. But as Dina's going to talk about in a little bit, you can have patients that have a normal RASS scale score and have evidence of disorganized thinking, and they have delirium. So that's how you can get it, either this way or getting this and this way. So let's start from the top. So step 1 is, does your patient have an acute mental status change? Or has the patient's mental status been waxing and waning over the last day? If yes, then you keep going and you determine if they have inattention. And how do we do that?
So you assess your patient for inattention by using the phrase save a heart. And it's heart with 2 A's, not an E. So basically you're going to tell the patient to squeeze your hand every time they hear the letter A, and you'll go through it, SAVEAHAART, and they have to squeeze your hand every time you say the letter A. If they have more than 2 errors, you'll continue on to their RASS score. But if they have less than 2 errors, then you're done and the patient doesn't have delirium.
So just to summarize this one more time. So you say this word and you ask them to squeeze your hand every time you say the letter A. And if they either don't squeeze your hand when you've asked them to or squeeze your hand when they shouldn't, those are considered errors.
That's correct.
Got it. So once you've determined if you feel the patient has inattention, then you've already assessed their RASS level, and if it's 0, then you have to move on.
Correct.
But if it is abnormal, anything other than 0, then your patient has delirium. You're done. If your patient has a RASS score of 0, then you keep going. And I know you wanted to make a couple important points about that.
Yeah, I sure did. So your patient can be alert and calm and answering questions what you may seem to think is appropriate, like, do you have pain? Somebody may say, yes, but they still could have delirium. So you can assess that by asking a series of questions. It's 4 questions. Or you can have them follow simple commands for you, such as holding up your fingers and asking them to hold up 2 fingers for you, adding another finger, or doing it on the other hand as well. So if you do that and they get no errors or 1 error, then again, they're negative. They don't have delirium. But if they only get 1 wrong answer, and if they get 1 wrong answer, then their delirium screen is positive.
So, so you're saying 0 to 1 is okay. More than 1 error, they have delirium.
Correct.
So, and you were saying the kind of questions you can ask. Did you want to go over any of those?
Sure. So there's a series of 4 questions. I'll just go over, for an example, one of them, will a stone float on water?
No.
So you may say no. So you
That's
wouldn't
good.
have delirium. That's good. But somebody who has delirium may answer and say, yeah, sure, a stone can float on water.
And you can see on the screen some of the other questions. So now that we have taken you through the process of determining if your patient has delirium, now the focus is, as you can see on the screen, now what? And the question is, what can you do? So the first thing you can do is you can see if there are any medications that can be lowered or stopped altogether, such as benzodiazepines. And as has been a theme throughout our video, the focus is to make sure that your patient is comfortable but not over-sedated. And again, we focus in on the concept of analgo sedation, treat pain first, and then if the patient requires sedatives, give them. And as you've pointed out to me, there are some titration strategies that I think you wanted to talk about here.
Yes, I did. And here at this medical center, it's a nurse-driven protocol, and basically the bedside nurse is the one who can assess the patient and make sure that they're at a proper RASS scale and decrease to give the patient the minimal amount of a sedative drip that they need. And they can even assess if the patient doesn't need the drip at all and could just use intermittent pushes and, bring it up to the team and say, this patient may not necessarily need the drips. How about we just give them some intermittent pushes? And as long as it's safe for the patient, that's something that we can go ahead with. So it's basically being minimalist and using the minimal amount of sedation possible.
So constant, big theme in critical care, intervention and reassessment.
Yes.
There are some other important points that we wanted to share with you, and that certain diseases that we deal with frequently in the ICU can be associated with delirium, such as shock, congestive heart failure, multiple organ failure, where the altered mental status may be the initial manifestation, hypoxemia, sepsis. But I wanted to focus in and let Dina talk about some of these important issues at the bottom of the slide that often may not be thought about, and I think that putting a brighter light on them could be important.
Yeah. So basically, if a patient normally wears glasses or hearing aids, if they don't have them on, put them on. The patients, it'll help them to be able to see and hear, decrease any loud noises around, or if we can control any noises such as alarms, to shut them off when they're going off. And what's really important is to get the patients into a sleep-wake cycle, and that they would be in at home, awake during the day, sleeping at night without being disturbed. So in the ICU, you have blood pressure cuffs going off constantly and constant blood draws, and even just regular bedside care that can maybe be pushed off until the morning, or do it earlier before the patient goes to sleep to let them get the best rest possible.
So patients can be misperceiving for simple reasons, like they're not hearing well, they can't see well, and they've lost their circadian rhythm.
Pretty much, yeah. So, here we went ahead with all of these non-pharmacologic interventions. Is there any medications that we can give for delirium if they don't work?
Another super important question. So I answer with pause here because this is a real hot area of critical care research. It's been very difficult to prove that any particular medicine improves long-term outcomes. It's very clear that drugs like neuroleptics, like haloperidol, and some of the atypical antipsychotics like quetiapine can help treat hyperactive delirium, but it's unclear if those drugs are helpful long-term. They are used, and again, it's important that the team be all on the same page about when we use them, what drugs we use, and importantly, as you can see on the bottom of the slide, the safety issues associated with these neuroleptics, including checking for QTc prolongation.
So how often should we be checking for the QTc prolongation?
Certainly when the patient first gets started on the drug, if they haven't been on it before, usually then for the first few days afterwards, and then afterwards we'll often be doing it on a weekly basis. So this is it. This is early exercise and progressive mobility. This is an incredibly important point. This is the E in the ABCDE bundle, and I wanted to take a moment and share with you what this is all about. The idea up until the last, I would say, 5 or 6 years was that we as critical care practitioners were so busy taking care of our patients who were so sick that our focus was to get them through their critical illness, and then we would focus in on rehabilitation. Sounds reasonable. Evidently it's not. And the focus now is to take that arrow pointing at the patient and saying, when do I start rehab, and bring that arrow to the minute they come into the intensive care unit. And it's a little bit confusing and startling when you first hear about it and see it, but the focus is that doing early mobility is a sign of a quality intensive care unit. So let's talk about it. So, Dina, this slide and the next slide are 2 protocols that are used. This is the one from AACN and this is the one from Johns Hopkins that helps people, bedside critical care clinicians, think about how to mobilize their critically ill patient, and I wanted to spend some time and work with you.
Yeah, that's correct.
I think the first thing that we wanted to talk about is that both sides have a safety screening, and maybe if you wanted to talk about this for a minute or two.
Yes, so the safety screen uses the mnemonic MOVE.
So these are patients who, if they meet all these criteria, you can start by assessing them for early mobility, right?
Correct.
Okay.
So, you want to make sure that the patient has cardiac stability, no evidence of any myocardial ischemia for 24 hours or dysrhythmias using any antidysrhythmics for 24 hours. You want to make sure that they're oxygenating well on low levels of oxygen and PEEP, and that they're on minimal vasopressors. Just because they're on vasopressors doesn't mean that they can't get moving. You just don't want to be titrating up for within the past 2 hours. And as long as the patient is engaged to voice and can respond to verbal stimulation, you can move ahead and you can start getting your patient going. So as you see here, you can start with level 1, which is passive range of motion 3 times a day, turning your patient and doing some active resistance if they can cooperate, moving all the way up to level 4, which is getting the patient up and moving.
So the focus is ambulation. The focus is a structured approach, doing your formal assessment at each level, and as you've said to me, if you meet the criteria at that level, try to move to the next level. Is that right?
That's correct. And just because the patient is intubated and on a ventilator does not mean that they should not be screened. You should be screening them, especially if they're on a ventilator.
So this is the protocol from Johns Hopkins, and we're using this at the medical center, and I think that you and I have gone over this carefully before, that the focus here that's slightly different. Again, the patient can be on some degree of pressors, the patient can be intubated, and the focus here is to making sure that they're able to interact with you. Am I saying that correctly?
That's correct.
And I think one of the important points that you've brought out before is even if you fail all of this, tell us what happens then.
So even if their patient fails the initial screening, they still get some sort of therapy. They still get some sort of physical therapy. And it doesn't have to be necessarily with the physical therapist. It could be anybody. It could be the bedside nurse. It can be the clinicians. It could even be the family. Because if they fail, then they're at a level 1, and their RAS scores usually will be like a -5 to 3, and you'll do more of a passive range of motion with the patient. And as you progress, once they do well with passive range of motion and you assess them and they're a little bit more awake, you can move on to level 2, 3, and 4, which the patient is more and more engaged and more active in.
And the focus here, as you've said, and it's beyond the scope of the video, and people should look at this in more detail, but you're going from some degree of activity, even if they don't even meet the screen,
Correct.
all the way up to walking, even if they're intubated.
Absolutely.
And we've actually done that a couple of times at the medical center. And the safety issues with it really have been studied aggressively and seem to be there. It's okay.
Mm-hmm.
So we're heading towards the end of the video. The focus of the ABCDE bundle, as you can see here with the improved outcomes, is a focus on awakening and breathing trial coordination, that we're making sure to carefully pick how much and what drugs we're using for analgo sedation, that we're assessing the patient for delirium, and that we're focusing in on aggressive early mobilization on the critically ill patient. There's a couple other points that Dina and I wanted to conclude with, just for completeness sake, is if you look on the Vanderbilt website at icudelirium.org, and we've got a screenshot here, They've made some minor changes.
What kind of changes have they made?
They're minor.
So we're not using the A, B, C, D, E that we were just going over?
It's still A, B, C, D, E. They've made some minor changes to the letters, and they've added a letter.
Which letter?
F.
And what does F stand for, Rich?
Family.
Oh, that seems pretty important that the family should be involved.
So what we're going to do now is I want to take a minute and share with you the subtle differences. Everything that we've talked about up to now is unchanged. They want you to have A begin for assess, prevent, and manage pain. And I know, Dina, there's a particular scale that we use.
Yeah, it's the CPOT scale to assess the patients for pain while they're intubated in the ICUs.
So this is not new and is something we do routinely. B stands for doing both a spontaneous awakening trial and spontaneous breathing trial. C, again, as Dina and I have been emphasizing throughout the video, is your choice of analgesia and sedation, making sure that you are controlling pain, and that you are using what is needed for the patient, but not excessive amounts of drug. That you're doing D, delirium assessment, that's no different. That E still stands for early mobility and exercise. And F stands for family engagement and empowerment. And again, we've got a slide here focusing in on just the very basics of some examples given by this website of thoughtful and early recognition of family distress. They mention using support groups and, importantly, helping to prevent caregiver burnout, making sure that family members understand that it's okay if they leave for a little bit and that them taking care of themselves really is important too, because we as the critical care team need the family members to have their own strength so they can help work with us to care for their loved one and help us make some important decisions as they come up. So that's really the focus of this video. We've ended by a slide here that just goes over the very basics, and I'm just going to touch on it here. We've addressed every issue already in the talk. The ABCDE protocol, a spontaneous awakening screen. If they pass the screen, do the awakening trial. If they pass the awakening trial, doing a spontaneous breathing trial screen. And if they do well then, doing a spontaneous breathing trial and extubating the patient. That the D stands for delirium, and that you're assessing your patient for delirium, that you're helping to do non-pharmacologic interventions, the ones you importantly mentioned, like orienting the patient, that you're helping to make sure if they have hearing aids or glasses and hearing aids, that those are on, and that we're doing everything we can to optimize that their circadian rhythm is as normal as possible, which we all know it can be very difficult. And then finally, E is early exercise and early mobility, and we really spent a lot of time on that. And so again, our conclusion here is we hope you've enjoyed watching our video on the ABCDEF bundle. And
you know, just to keep in mind that it's really important to keep the families and patients at the center of our care every day.
Thank you so much for watching. See
Thank
you
you.
later.